Good morning, everybody. This is a very important topic in the field of nephrology, which is anemia, the anemia of chronic kidney disease. And I'm going to speak about the most recent update this month, February 2018. So I'll start with the introduction, pathogenesis, and evaluation. Then I'll discuss one of the important pillars in the management of iron therapy, erythropoiesis-stimulating agents, adjuvant treatments, and in the case of resistance or hypo-responsiveness to ether therapy, then hypoxia-inducible factor stabilizers, and I'll end with special issues. So let me to start with this slide. I always like to speak about the anemia in chronic kidney disease, and this was a last recording in 2016, the end of 2016. Let us go to some important points from the basic knowledge up to the most recent publications. To start with, hemoglobin cutoff point for definition of anemia in people living at sea level depends upon the gender and age. So if we are here in the age of children, in this age range, if it is less than 110 gram per liter or 11 gram per deciliter, from 5 to 11 years, 11.5 gram per deciliter, 12 to 14, it is 12 gram per deciliter. In non-pregnant females, adult, if it is less than 12 gram per deciliter. In men, if it is above 13 gram per deciliter. So this is the first important point. You want to say anemia. And in Japanese people, the correlation of hemoglobin level with chronic kidney disease, the presence of anemia, especially if it is less than 10 gram per deciliter, from early beginning, there is increasing death and the end-stage kidney disease. In the early stages, the link of anemia with this is very prominent, and in the advanced stages of chronic kidney disease, the presence of anemia, especially if it's less than 10, the higher the risk of end-stage kidney disease. Again, hemoglobin in the Japanese patients, if it is less than 10 gram per deciliter, is associated with end-stage kidney disease in advanced stages and mortality in the early stages of CKD. The treatment of anemia is important because it's associated with improvement of quality of life, increasing exercise capacity, improving cardiac output, reducing ischemic heart disease, reducing left ventricular hypertrophy, improving bleeding tendency because red cells are important for the functions of platelets, improving cognitive functions of the brain, reducing depression percentage, improves sleeping pattern, improves sexual dysfunction, improve endocrine dysfunction, immune function, increasing muscle metabolism, reducing hospitalization, decreasing the necessity for blood transfusion, and improving nutritional status of the patient. In this cohort of patients, the anemia was associated with stroke. This cohort included 3,400 patients undergoing maintenance prevalent hemodialysis. Hemoglobin is categorized according to the level of hemoglobin into 4 quartiles. Quartile 1, it is low hemoglobin, up to quartile 4, it is 11.2 gram per deciliter. The presence of low hemoglobin, quartile 1, is significantly associated with increasing the cumulative incidence of hemorrhagic stroke. This means that anemia is very important and should be covered and managed. So how to evaluate? The most updated renal association guidelines that were published in 2017 recommend that all patients with chronic anemia associated with chronic kidney disease should be investigated for the cause and possible treatment, irrespective of the grade of kidney disease or requirement for renal replacement therapy. If hemoglobin levels are less than 11 gram per deciliter or less than 10.5 gram per deciliter if younger than 2 years, or they develop symptoms attributable to anemia. And this to ensure the correct diagnosis and management of anemia, and this is a strong evidence. The question is, what are the pathogenetic mechanisms and essential for anemia? It is needless to say, is a deficiency because erythropoietin is secreted from the kidney. So if there is kidney dysfunction, is a deficiency there. Starting from the early stages, starting from stage 3 CKD, if SMEGFR is less than 60, erythropoietin level is reduced. Then we may have factors easily correctable, or potentially correctable, or impossible to correct. It's very important to know these points, because if we know that there are easily correctable factors, we can manage them, or potentially correctable, we can modify them. So easily correctable factors are absolute iron deficiency, vitamin B12 and folate deficiency, hypothyroidism, the use of angiotensin converting enzyme inhibitors or angiotensin receptor blockers, and non-adherence. Potentially correctables: infection, under dialysis, inflammation. Under dialysis is important because we should do proper dialysis for our patients. Bleeding, so we should search of the source of bleeding. Hyperparathyroidism, so there is a link between CKD, MBD, and anemia. Puerperal aplasia, malignancy, and malnutrition. So it's better to address all these factors to know the presence of any of them. If they are easily corrected, we should correct. If they are potentially correctable, it's better to modify. And if there is hemoglobinopathies or bone marrow disorders, severe form, these are impossible to correct, so we can manage the patient according to this basis. A very recent article in children, these are the etiology of anemia of chronic kidney disease in children, and I think all these factors can work in adults the same. Erythropoietin deficiency or dysregulation, iron restricted erythropoiesis, either absolute or functional deficiency. Absolute means the iron stores are deficient. Functional iron deficiency is there is sufficient iron in the stores, but it's not available for the function. And we can diagnose them by looking at ferritin and transferrin saturation. In absolute iron deficiency, both ferritin and the transferrin saturation are reduced. In functional, ferritin is high, but transferrin saturation is reduced. Impaired iron trafficking, inflammation and hepcidin up-regulation. This is cytokine responsible for our resistance because it reduces the availability of iron. And then chronic blood loss, frequent phlebotomy, hemodialysis, circuit losses, because this is inevitable. Each dialysis session there is some blood withdrawn or removed through the lines. Gastrointestinal losses, menstrual losses, uremia or oxidative stress, hyperparathyroidism or myelofibrosis, nutritional deficiencies, vitamin B12, folate, carnitine, and vitamin C, using of ACE inhibitors, non-adherence, drug toxicity, and puerperal aplasia. Again, these are the same factors that I mentioned in adults, so it works in children. The guidelines suggest that hemoglobin level should be routinely measured to screen for anemia, at least annually in stage 3 chronic kidney disease, and twice a year in a patient with CKD stage 4 and 5 and not yet on dialysis. And this is the core curriculum that is published in press. We should have a focused history, and physical examination is mandatory, and these are important points to be thoroughly evaluated. Blood testing chemistries, complete blood count, including red blood indexes to know if it is normocytic, microcytic, etc. Reticulocyte count, serum ferritin, transferrin saturation, folic, and vitamin B12 levels. Should we measure erythropoietin? The answer is no. The recommendation stated that we shouldn't routinely measure the erythropoietin level for diagnosis or management of anemia associated with CKD. Regarding iron therapy, according to this National Clinical Guideline Center release on June 2015, we can diagnose iron status based on certain laboratory tests. Here, using percentage of hypochromic red cell, if it exceeds 60%, this means that there is absolute iron deficiency. But the problem of this test should be done if processing of blood sample is possible within 6 hours. If using a percentage of hypochromic red cell is not possible, use reticulocyte hemoglobin content. And absolute iron deficiency is defined if absolute of reticulocyte hemoglobin content is less than 29 picogram. If there is a problem of using these two tests, so we should depend upon both serum ferritin and transferrin saturation. So transferrin saturation less than 20% and ferritin less than 100 microgram per liter. These are the criteria of absolute iron deficiency. Don't request transferrin saturation alone or serum ferritin alone to assess iron deficiency status in people with anemia of CKD. So we should know both transferrin saturation and ferritin. As I mentioned before, if both of them are reduced, this means absolute iron deficiency. If ferritin is high and transferrin saturation is reduced, this is a functional iron deficiency. The evolution of iron therapeutics started from early decades here. Oral iron was there, iron dextran, then in 1999 sodium ferrigluconate, then in 2000s iron sucrose, formixtol in 2009, ferric carboxymaltose in 2013, ferric citrate was added in 2014, and the most recent addition in the management of iron is ferric pyrophosphate citrate added to dialysate. If we treat with iron, we can treat patients who are not dialyzed still in the pre-dialysis era by giving a chance of oral iron. But the most important lesson is when we decided to give oral iron, we should give iron in a suitable duration and a sufficient dose. So, and the dose of iron depends upon elemental content. So these are the different iron salts, and this is the dose in milligram, and this is elemental contents per the dose here. So if we give this drug, we want to give 200 milligram because of sufficient dose is 200 milligram per day for eight weeks. So we should look at this. So here we should give 3 tablets per day. So if the patient tolerates well and hemoglobin is fine, everything is fine, is okay. But if the patient is not tolerating oral iron, or there is no response after sufficient dose and sufficient duration, we should shift to parenteral iron. These are the different parenteral iron names: formixtol, carboxymaltose, and dextran, iron sucrose, and ferrigluconate. And these are the physicochemical and the pharmacokinetic characteristics. And it's better to fix this slide and look at every point in this table. But here I want to say that here the catalytic iron release here is very high with the old form of iron and iron dextran, iron sucrose, and ferrigluconate. And this refers to stability. So the relative stability of elemental iron within the carbohydrate shell is very high in the recently introduced forms, but it's medium in iron sucrose and low with ferric gluconate. Again, these are the different names: sodium ferrigluconate, ferlicet, iron sucrose, venofer, ferric carboxymaltose, injectafer, low molecular weight cosmofer, iron isomaltoside, it is monofer, and formixtol ferriheme. And this is how the formulation is introduced, and this is the maximum dosage for each one of them, and it's better to look at the maximum dose and not to reach it. And this is the minimal administration time, and so we should think of each one of them and to know the maximum dose and the rate of intake of the drugs. And this is in a very simple manner the FDA approval of the different drugs. And here the repletion dose in hemodialysis, for example, in iron sucrose, 100 milligram per dialysis session. In CKD, no dialysis, 200 milligram per dose for 5 doses over 14 days. So it is 1000 milligram And here it is 1,000 milligram of ferric gluconate, 125 milligram for 8 sessions. And for stool, 510 milligram, giving twice, 1 week apart. Ferric carboxymaltose is 750 milligram, and second injection can be given 7 days later. So we can give big doses from these formulas. And in iron dextran, it's better to look at hypersensitivity and the low, and we can calculate the dose based on this calculator. Regarding the effect of intravenous iron on monocyte, and this is one of the most important points, that the iron may impair monocytes. This means that increases the risk of infection. And here, if we look here, this is the red colored formulas of iron sucrose and sodium ferrigluconate. Red color here refers to the risky for disturbing monocyte function. This is why in active infection we may not give parenteral iron. Ferric carboxymaltose and isomaltoside, the newly introduced forms, are stable and don't affect the monocyte function. Again, oral or IV, this is one of the randomized control trial, including few number of patients, showing some side effects of parenteral iron, like hospitalization and cardiovascular problems. But this is the meta-analysis and review here showing that the use of IV iron is effective. So it is effective, and there is no significant side effects in comparison to oral iron. So it is very wise to use parenteral iron, but if we are interested in oral iron, we should give it to patients in the pre-dialysis era, given in proper dose and for sufficient duration. The issue of iron and phosphorus, anemia and phosphorus, this study shows that the issue of serum phosphorus and anemia follows U-shaped curve. So high level of phosphorus is associated with anemia, and the very low levels are associated with anemia too. The majority of cases, the higher phosphorus, the higher the risk of anemia. And this paved the way for the use of new phosphate binder to bind phosphorus and in the same moment replenish iron. It is ferric citrate. In this study that included 411 patients in a randomized control trial, the comparing ferric citrate to active control from other phosphate binder in 52 weeks study, there was effective phosphate binding like other phosphate binders, but with the bonus of saving $2,000 per patient per year from saving anemia management. And this is the ferric pyrophosphate citrate added to dialysate. It is the study shows the efficacy of this style in replenishment of iron, because in dialysate, when we add it to the dialysate, it gives the body 6 milligram per day per dialysis session, and this is very physiological, and we are avoiding high elemental iron giving to the patient. So I think if it becomes available, it will be very nice for our patients. Again, the renal association guidelines, the definition of adequate iron status is very important. Serum ferritin should be between 200 and 500 microgram per liter in hemodialysis patients, 100 to 500 microgram in non-hemodialysis patients, and either less than 6% hypochromic red cell or reticulocyte hemoglobin above 29 picogram, and transfusion saturation is above 20%. These are the criteria of success of treatment of iron deficiency. And regarding the guidelines recommendations for treatment of anemia with iron therapy, they suggested oral iron in general be sufficient to maintain and may be sufficient to attain the hemoglobin within target in ESA-treated CKD patients not yet requiring dialysis, and those on peritoneal dialysis. So, and this is rational to give these patients on PD or on the pre-dialysis the oral form. For CKD patients not requiring hemodialysis, the choice between oral versus parenteral iron depends on the severity of iron deficiency the previous response and side effects, the availability of venous access, and the need to initiate ether therapy. In contrast to the most hemodialysis patients will require intravenous iron. When offering intravenous iron therapy to people not receiving in-center hemodialysis, consider high-dose, low-frequency intravenous iron guided by the pharmacokinetics as I mentioned in the previous tables. Regarding the guidelines about the upper limit for iron therapy, they recommended that serum ferritin shouldn't exceed 800 microgram per liter in patients treated with iron, and to achieve this, iron management should be reviewed when the ferritin is above 500 microgram per liter. And this is regarding infection. If there is active infection, the guidelines suggested avoiding parenteral iron in these patients because we are afraid of disturbing the phagocytes and monocytes, as I mentioned before. But the most important point is we should put in mind iron deficiency because it seems that there is clinical inertia in the management of CKD-associated anemia by giving ether therapy and neglecting iron. So it's better to consider because women at early stages and men at advanced stages are having iron deficiency. So before giving ether therapy, we should look at iron indices. Regarding dose and effect in 1,679 incident hemodialysis, the relationship between iron dose, hospitalization, and mortality in incident hemodialysis patients is shown here. This is the quartile of iron therapy in milligram per kg per month. Here, as you see, it is 1, 2, 3, 4, 5. And this is the color code. And this is the cumulative survival. So it seems that high dose is bad and associated with high hospitalization. Again, this is the quartiles. If it is here above or less than 5.5 or 5.6. If it is above, this is if it is less than, this is the survival. Above 5.6, this is survival. So it seems that it affects the survival of the patients. This is for full cohort, but after following propensity matching, this side effect is not manifest. Again, to know the best iron strategy for management of the patient, I think we are waiting the results of pivotal trial design. This is the study of incident new hemodialysis patients from 0 to 12 months before 1 year on ether therapy. And the patients are either treated with proactive intravenous iron R, intravenous sucrose iron 400 milligram per month, withhold if ferritin exceeds 700, and TSAT above 40%. And reactive minimalistic intravenous iron R, give intravenous iron if ferritin is less than 200 or TSAT is less than 20%. And we are waiting the result of this randomized study to know the issue of the best use of iron. Regarding ether therapy, is a main erythropoiesis stimulating agent, and this is one of the slides from the previous even recording. We have the different EPOs, and even we have sotatercept. Sotatercept is this fusion protein that inhibits the effects of transforming growth factor beta on erythropoiesis, and we have hypoxia-inducible factor stabilizer. And this table shows all the available erythropoietin or ether therapies. We have epoetin alpha. This is the first generation, and epoetin beta. This is the name, the trade name. You can see the trade name here. Epoetin alpha is like here Ebrex, and this is epoetin beta hormone. And this is the omega, and this is the second generation epoetin beta new hormone, darbepoetin alpha aranesp, and third generation including microsera. So these are the different names and different brands, and even the biosimilar can be used. And this study shows the efficacy of HX 575 established biosimilarity in the treatment of renal anemia and 10 years of clinical experience. Regarding the other armamentarium, these drugs, hypoxia and distal factor stabilizers, activin trap like sotatercept, and these epotin mimetic, epofusion protein, antibody agonists to EPO receptors, EPO gene therapy, dimerization of EPO receptor, all these are different issues. Let us go to the practical point. What is the difference between the most available ESA therapies? Regarding room temperature, I think this is a very important clinical point. Epoetin alpha shouldn't be out of the refrigerator, and the epoetin beta can stay 5 days. The darbetin alpha can stay for 7 days, and sera for 31 days outside the refrigerator. So this is the room temperature shelf life in epoetin alpha 0, and this is the shouldn't be away from the refrigerator. And this is an advantage for the long-acting ether therapy. Regarding the dose, and I think this is from the previous recording, epoetin can be given in a dose of 50 to 100 units per kg, administered intravenous or subcutaneous 3 times per week. Darbetin, the dose is 0.45 microgram per kg, administered as single intravenous or subcutaneous injection once weekly. Sera, 0.6 microgram per kg, administered as single intravenous or subcutaneous injection once every 2 weeks. This is in the initiation phase, and you can shift in the maintenance phase to darbetin every 2 weeks and sera every month. So this is the starting dose, and previously it was very wise to monitor hemoglobin on a weekly basis in the starting of the treatment to know the trend in the rise of hemoglobin. And currently we may follow in the initiation every 2 weeks, and after that every month for hemodialysis patients. So the guidelines recommended that initial ether dose should be determined by the patient hemoglobin level, target hemoglobin level, the observed rate of increased hemoglobin, and the clinical circumstances. All these are important points, and this is regarding the half-life for the different forms for intravenous or subcutaneous. And you can see here half-life here is prolonged for all the, especially the short-acting, the epoetin alpha. Regarding the low dose versus high dose fixed formula, I think it is not rational at all to follow fixed dose, because this study here, they are starting the study by high and low, and eventually after a period of time both of them are approaching each other. So it was not practical to follow fixed low or fixed high dose, because we are monitoring the patients. If we start on one of the brands and we wanted to change it to the other, we can change based upon the equivalent dose. So you should follow the equivalent dose that is written here in the tables, or just you can write on the Google or the internet which is the equivalent for this dose, and you can find the low. So we can change between the different brands of ether therapy. Regarding short acting, this is not convincing data, because they looked at if we can give short acting erythropoietin on the more frequent or less frequent by giving larger dose instead of small frequent doses. So epoetin alpha given at higher doses for extended intervals, 2 or 4 weeks, is non-inferior to a more frequent dosing interval in maintaining final hemoglobin level, with no significant differences in adverse effects in non-dialysis CKD patients. But again, the analysis of these studies showing that their evidence and their quality is very low, and it's not convincing for me. So the question is, which ether to be used? It is epoetin alpha, beta, darbetin, or sera. This is the meta-analysis, very nice. 56 studies, including 15,000 patients. And here, if you look at different variables, there is no significant difference between all of them. Regarding mortality, regarding the cardiovascular mortality, regarding myocardial infarction, stroke, hypertension, AV fistula closure. So at the end of the day, we give what is available to the patient and according to the patient preference. So the guidelines recommended that the decision on the choice of ether is based on local availability of ESA therapy. And this is from the old KDIGO guideline 2012. Before giving ESA therapy, we should have a good history from the patient. There is a history of convulsion, history of malignancy, history of any side effects and complications, and as well as the examination and the laboratory investigation for iron status, because it is not logic at all to start ether therapy while the patient is in absolute iron deficiency. So this is a very important point to be considered. And this table summarizes the suggestive contraindication, or at least precautions. If there is previous history of thrombotic vascular event in the past 6 months, like myocardial infarction, cerebrovascular accident, transient ischemic attack, DVT, pulmonary embolism, all these should be put in mind when we decide to give ether therapy and to calculate the dose properly. And here there is a caution. Previous history of seizure, uncontrolled hypertension, so we should at first treat hypertension, then give ether therapy. Risk factor predisposing to DVT, like immobility and fracture joint, hypercoagulable state, cancer diagnosis, all these should be put in mind before giving ether therapy. The side effects may be seizures, increased blood clotting, a slight decrease ZKT over V. Why? Because when we treat anemia and the red cell increases, the extraction of uremic toxin from red cell is slower and less efficient than extraction of uremic toxin from serum. So we should monitor dialysis adequacy, impaired phosphorus balance, hyperkalemia, urethral aplasia, and worsening of hypertension. So this is why we should be aware of the hypertension, and the guidelines recommend that blood pressure should be monitored in all patients receiving ESA therapy, and present hypertension to be treated by volume removal and or antihypertensive drugs. And this is recommendation based on good evidence. Regarding the route, sub-Q or intravenous, this study assured the safety and efficacy of subcutaneous with cost saving. And this study included here 57,000 patients received intravenous and 5,000 received subcutaneous. And the subcutaneous route is associated with effective and dose reduction, 25% cost reduction. What about adjuvant treatment? From the KDIGO guidelines, there is they recommended not using androgens as an adjuvant to ether therapy, and they suggested not using vitamin C, vitamin D, vitamin E, folic acid, L-carnitine, and pentoxifillin. Regarding L-carnitine, it can be given if we document the L-carnitine level in a patient with manifestations of L-carnitine deficiency. If there is deficiency, we should supplement. Regarding resistance or hyporesponsiveness, the recent guidelines recommended that inadequate response resistant to ether therapy is defined as failure to reach the target hemoglobin level despite sub-Q EBT dose in a range of 300 international unit per kg per week, or 450 unit per kg per week intravenous, or darbepoetin more than 1.5 microgram per kg per week. Hyper-responsive patients who are iron depleted should be screened clinically and by investigation for other common causes of anemia, like inflammation and others. Again, hyperresponsiveness is associated with problems for the hemodialysis patient. And the lessons from this study is the hyperresponsiveness is witnessed in the early period before reaching end-stage kidney disease. If you look here, this is the mean hemoglobin for non-end-stage kidney disease, and for end-stage kidney disease you can find here reduction of hemoglobin. And again, this is for placebo, and this is for darbepoetin. So even in darbepoetin there is a trend for lower hemoglobin when the patient approaches end-stage kidney disease. So we should be careful in the period of transition from advanced CKD to end-stage kidney disease, because it's associated with reduction of responsiveness to ether therapy. As you see here for darbepoetin, there is increasing the need for the dose to keep hemoglobin. Again, this is ferritin. There is higher ferritin in the period of end-stage kidney disease, and higher C-reactive protein, the blue color, means that there is increase. And so the mechanism may be inflammation, because C-reactive protein and ferritin are increased, and the response to ether therapy is reduced in the end-stage kidney disease. The other pathway, we mentioned the inflammation and C-reactive protein. The other pathway is serum adiponectin. Serum adiponectin is released from adipocytes and released as well from the fat bone marrow, from the fat in the bone marrow. So here the adiponectin level, and this is the estimated GFR. With reduction of estimated GFR, adiponectin level is increased. With increasing adiponectin level, hemoglobin level is reduced. So it seems that there is a link between adiponectin and the anemia. And this is the quartiles of adiponectin. Here the quartile 1, quartile 2, quartile 4. And if you look at quartile 4 is associated with cumulative anemia development, higher cumulative percentage. The explanation is if the adiponectin is released from fat marrow, so fat marrow can expand, and this can explain the reduction of the capacity of bone marrow to form red cells. Again, the inflammation hepcidin may have a role, because hepcidin is cytokine released from hepatocyte liver, and this inflammatory cytokine leads to reduction of availability of iron, and leading to the resistance. And you can see here the hepcidin leads to reduction of iron, of availability of iron from the iron stores, as well as from the gastrointestinal tract. So it is, again, it's important to think of all pathways, adiponectin and inflammation. Regarding hyperresponsiveness, here this is a very interesting study, showed that high volume online hemodiafiltration may improve the ESA resistance. This study included few number of patients, 40 patients. They started either bicarb hemodialysis or online hemodiafiltration, high volume, for 6 months, and then crossover of treatment to in the second phase. And the study shows that the hepcidin or hepcidin is an important risk factor for hyperresponsiveness, and it is improved by high volume online hemodiafiltration. And this is why high volume online hemodiafiltration increases the clearance of small and medium molecule, reduces plasma hepcidin, reduces inflammation, and reduces oxidative stress. This will be translated into ESA, improvement of ESA resistance, and improving survival. Maybe for the use of the more physiological water, ultra pure dialysate with less inflammation, maybe. One of the important points when we diagnose hyperresponsiveness, we should think of the failed graft. This is a case, and here this is the hemoglobin, and this is the hemoglobin in the solid line, and the interrupted line reflects the darbepoetin dose. Here, hemoglobin was fine, and darbepoetin dose was fine, but after that, hemoglobin is reduced, and darbepoetin dose is even multiplied 4-fold. But after doing transplant nephrectomy, the need for darbepoetin is reduced and hemoglobin is maintained. This means if we have a patient who was previously transplanted and resumed the dialysis because of graft failure, we should think of the causes of ESA resistance. If he develops secondary resistance, this may be due to the inflammation environment induced by the graft. So we should measure inflammatory parameters like C-reactive protein. If it is high, this may be an indication for graft nephrectomy. Again, ESA resistance may be primary. The patient doesn't respond from the start, or maybe secondary after a period of time. In the presence of ESA resistance, and instead of going to very, very high doses of ether therapy, it's better to use a proper dose to avoid blood transfusion. And even if the patient needs a blood transfusion and will stop ether therapy, the frequency of blood transfusion will allow us to decide to resume the dose that allow for less possible blood transfusion. Regarding hypoxia and dyspnea factor stabilizer, so long as the hepcidin and the hypoxia are affecting the iron availability, the use of hypoxia, hypoxia and dyspnea factor stabilizer are essential to keep hypoxia and dyspnea factor stable. The stability of hypoxia and dyspnea factors improves the release of iron and reduce hepcidin. So we can use hypoxia and dyspnea factor stabilizer like the prolyl hydroxylase inhibitors. It will improve the availability of iron and reduces the dose of EPO because it releases iron and EPO. Regarding the other GATA, here GATA also this is the pathway of GATA 1, GATA 2, GATA 3, GATA 4. So giving this drug, which is a GATA inhibitor, will improve as well the treatment. So again, using a hypoxia and dyspnea factor stabilizer will help in improving erythropoiesis. And these are the different names of the drugs in this class. And this is the company. You can go one by one to read. And nowadays we are waiting the results of the phase 3. So in this is roxadustat, phase 2b. The drug was very beneficial, and this is another study. So the use of this class of drugs, hypoxia and dyspnea factor stabilizers, may be a solution in the future because one of the advantages is the drug is given oral. Secondly, it improves the availability of iron and erythropoietin. Regarding some of special points, hemoglobin variability is very important. Pre-interstitial disease hemoglobin variability predicts post-interstitial disease mortality in patient transitioning to dialysis. So it is very crucial and very important to look at hemoglobin in stage 4 and 5, because here if we are dealing with the hazard risk for mortality and for either cardiovascular or not cardiovascular, all these are increased with high variability. The question: if there is a link between the use of certain ether therapy and variability, the most convincing data is no. There is no relationship between the brand of ether therapy and variability, although you can find some studies referring to the long-acting drugs may be associated with this variability, but I am convinced by how we treat the patients and how we monitor them. So we should treat the patients in a vigilant way and monitor them proper. Regarding pleural cell aplasia, here the guidelines don't recommend screening for anti-erythropoietin antibodies among CKD patients, and the diagnosis is based upon. So the diagnosis of ESA-induced pleural cell aplasia should be considered whenever a patient receiving long-term ether therapy, more than 8 weeks, develops all the following: sudden decrease in hemoglobin concentration at the rate of 5 to 10 grams per week, or requirement of transfusion at the rate of approximately 1 to 2 per week. Normal platelet and white cell counts, absolute reticulocyte count less than 10,000 per cubic liter. And they recommended that all ether therapy should be stopped in patients who develop ESA-induced pleural cell aplasia, and recommending that patients who remain transfusion dependent after withdrawing ether therapy should be treated with immunosuppressant medication guided by the level of anti-EPO antibodies. Regarding cancer, it's better to discriminate between, is it cancer-related anemia, and in this scenario we transfuse the patient if symptomatic, ESA not approved in this setting, or it is myelosuppressive chemotherapy induced, and according to the half-life of the patients, if we are expecting long life, red cell transfusion preferred. Use of ESA should be based on benefit-risk discussion with the patients. Not long life and symptomatic, use ESA at lowest possible dose needed to avoid red blood transfusion. Asymptomatic with the risk factor to develop symptomatic anemia the same, and then maintain hemoglobin between 10 to 12. Avoid increase in hemoglobin above 10 gram over 2 weeks. Discontinue ESA following completion of chemotherapy. Asymptomatic without risk factors to develop symptomatic anemia, observe the patient, not give ether therapy. Anemia related to other causes, treat the condition that has caused the anemia. So at the end, we should be cautious in the presence of cancer. One of important point, is there a link between the dose of ESA therapy and development of cancer? This study shows that the higher dose here, if it is above the darbopitin above 70 microgram, the adjusted hazard odds ratio of malignancy increased to 1.76, and the adjusted 1.94 is between 15 to 12 months. And this, so we should be careful. We should avoid the big doses of ether therapy. So here, 70 microgram or equivalent dosage to 70 microgram from other brands. Is there a link between the use of ESA therapy and renal protection in chronic kidney disease? This is a randomized placebo-controlled trial, shows no difference between placebo and sera regarding kidney protection. Again, the meta-analysis is not convincing this issue, so it seems that there is no link between ESA and CKD progression. Anemia of post-transplant anemia, the guidelines recommended suggested that treatment guidelines for anemia in renal transplant patients should be similar to those for CKD patients not on dialysis. However, this is a report of 3 cases of variceal aplasia related to tacrolimus, and I think it is very rare. The current trend after trial is reducing the dose, but the risk is a lower cut-off point, lower verge of hemoglobin. And if we look at the percent distribution of hemoglobin level among prevalent hemodialysis and peritoneal dialysis in the United States, this in hemodialysis, this is less than 9 to 10, 10 to 11. So here this is there is a reduction. But here in peritoneal dialysis, the fraction of patients with hemoglobin above 12 is more than hemodialysis. And if we look at the data of the system of this year, from 1995 up to the current era, here in the past, the hemoglobin was here, the level was above 12 here in 2005 and 2006. This is a fraction, so there was a trend to give higher dose to reach high target hemoglobin, but again, there is a trend nowadays to reduce the dose, and this means that you can find here increasing the percentage of patients with less than 9 gram per deciliter. So if we follow low dose, we should be aware of the risk of blood transfusion. And if we think of transplantation, it's better to avoid blood transfusion at all. Regarding the treatment, we should monitor the patient well. We can use the computerized system to support the treatment of the patients. Regarding the target hemoglobin, I think this is one of the important questions, which target we should follow. The guidelines suggest that patients with CKD on ether therapy should achieve hemoglobin between 100 to 120 in adults, young people, and children aged 2 years or older, 95 to 115 gram per liter in children younger than 2 years of age, reflecting the lower normal range in this age of patients. And they suggest that this hemoglobin target range applies exclusively to patients receiving ether and are not intended to apply to the treatment of iron deficiency in patients receiving iron therapy without the use of ESA. So if we document absolute iron deficiency, we should replete iron, even if it gives us a hemoglobin more than this target. So this is a target after giving ether therapy. And if we look at this important figure here, if we are here, this is the color code reflects the benefit. If we go to the high level, this will be associated with increased risk without additional benefit. If we treat these patients, there is a clear benefit with no evidence of risk. So they recommend, regarding blood transfusion, the guidelines recommend that in patients with anemia of CKD, especially those in whom renal transplantation is an option, red blood cell transfusion should be avoided where possible to minimize the risk of allosensitization. But if the general condition of the patient is dictating and there is urgent indication of blood transfusion, we should transfuse the patients. We recommend, if red blood transfusion becomes essential, usually in the setting of acute blood loss or acute hemolysis or severe sepsis, transfusion should be based on policies set by local transfusion guidelines rather than hemoglobin target for ether therapy in chronic anemia of chronic kidney disease. And the guidelines recommend that renal transplant recipients or those on transplantation waiting list or patients on immunosuppressive therapy should receive only hepatitis E negative blood components. And in our center, we use, if it is extremely indicated for those in the preparation of transplantation, we use leukocyte filter. One of important suggesting readings, this is the clinical practice guidelines of anemia of chronic kidney disease from the Renal Association. It was issued in June 2017 and is valid up to 2022, and it is released in 49 pages, and I recommend all of you to read this in details. At the end, we need a lot of science, and we are waiting many studies for the safe treatment of anemia. Thank you very much, and I'll be happy if you have any questions to send to my email. Thank you for attention and goodbye.